our learning objectives for this talk, we'll see which MRI sequences are best to evaluate articular cartilage, how to assess articular cartilage on standard sequences. We'll look at the effect of scanner field strength. We'll look at newer techniques of cartilage mapping and how to assess repair cartilage. So which sequences are best? On standard sequences, we look at articular cartilage morphology, the thickness. We look for fissuring, fibrillation, flap tears. So we need high resolution. That's the most important. This will give us good differentiation of articular cartilage from joint fluid and subchondral bone. And the best sequence for this in general is proton density with fat saturation. It may be called PD FAT-SAT or T2 FAT-SAT. And this is our workhorse sequence for cartilage imaging. You can recognize it because fluid will be bright, bone marrow and fat will be dark. The articular cartilage is gray, intermediate signal, and chondral lesions will be bright. We should also look at articular cartilage on all sequences that are available. Sometimes we'll see very good views of articular cartilage on our standard proton density image, especially if it's done with real high resolution. That can be a very good sequence. You may hear about 3D gradient echo with fat saturation. These are very thin slices. The articular cartilage is bright. It really stands out. Fluid and bone are dark. Unfortunately, chondral lesions are dark, and sometimes they're not very conspicuous. So this is good at looking at overall cartilage thickness and volume. It's a little bit harder to assess small lesions. When we look at cartilage, we assess the thickness, morphology, and signal, and we can use a modified outer bridge classification system. Normal cartilage should have uniform thickness, a smooth surface, and homogeneous signal. We may see zonality on high-resolution scans in younger patients. Here's a young patient where we can see deep transitional and superficial zones very nicely. Grade 1 chondromalacia will show some diffuse increased signal within the substance of the cartilage. The cartilage will be morphologically normal. Here we see a smooth surface, but inside the cartilage we see some diffuse increased signal. Grade 2 chondromalacia will show thinning or fissuring involving a depth of less than 50% of the cartilage. As we see here, there's about 25 to 50% thinning. The surface is a little bit irregular, and the signal in the cartilage is a little bit bright. Grade 3 chondromalacia is similar, but it's going to involve greater than 50% of the thickness. Here's a good example. This is involving about 50 to 75% of the cartilage thickness. We can see an irregular surface with fibrillation and increased signal. And then grade 4 chondromalacia is full thickness cartilage loss. We see no gray articular cartilage at all, or just right down to the bone. Flap tears become easier to see as you get higher resolution images. They just look like flaps. The key thing is getting good images, and then you'll see them very easily. Same thing with delamination. You just see this linear signal at the base of the articular cartilage. How does field strength affect imaging of articular cartilage? Well, the higher field strength gives you higher definition, and we have significantly better visualization of articular cartilage and chondral lesions. Here's the same patient scanned at 1.5 and 3T. On the left, this area basically looks normal. On the right, you can see there's some deep fissuring. I don't know if it's projecting real well, but you can see deep fissuring and a small flap. Also notice that the meniscal tear shows up more clearly at 3T. Standard MRI sequences look at gross morphology of articular cartilage. Cartilage mapping sequences evaluate articular cartilage at the biochemical level. They have shown potential to detect articular cartilage damage not evident on standard sequences. We can detect lesions earlier and with greater sensitivity. This is predominantly used in research, but some sequences are becoming available for clinical use. There's a variety of types of cartilage mapping, which we'll look at. And these are going to evaluate either collagen structure or proteoglycan matrix. First is T2 mapping. Collagen damage in articular cartilage results in T2 prolongation. T2 mapping sequence measures the T2 values of cartilage and displays it as a color map. This is an additional sequence to the normal study. It takes about 7 minutes. No contrast is used, and it is commercially available. And this is what it looks like. This is one slice from a mapping sequence. And the normal cartilage is going to show up as your orange and yellow colors, and green and blue will be more abnormal. In this patient on the left, we have a standard image showing grade 2 chondromalacia with fissuring. And on the right, we see the green colors in this area, which corresponds to T2 prolongation, representing collagen degeneration. This is the patient we looked at before with some deep fissuring in the articular cartilage on the left. And then on cartilage mapping, we actually see a larger area of abnormality with the green-blue colors corresponding to areas of collagen degeneration over a wider area than we can see on the standard image. DGEMRIC stands for Delayed Gadolinium Enhanced MRI of Cartilage. We're looking at proteoglycan content, which is decreased in areas of cartilage damage. And the proteoglycans are negatively charged. They repulse gadolinium ions. When we inject gadolinium intravenously, it diffuses into the joint and preferentially into abnormal articular cartilage. We then measure the T1 shortening and make a color map. This requires intravenous injection followed by a 90-minute delay and a 6-minute scan. So this is a very inconvenient type of scan, and it's not commercially available. This is what it looks like. Again, we see these green-blue colors in an area of chondromalacia, which corresponds to decreased proteoglycan content. T1 row mapping also looks at proteoglycan concentration. It's inversely proportional to the T1 row relaxation time. We perform a sequence which measures this and displays it as a colored map. Again, this is an additional sequence. There's no contrast needed, and it's not commercially available. This is what it looks like. Here the color map is inverted so that the red is abnormal. We can see the area in the posterior aspect of the tibial plateau and then the corresponding arthroscopic image of a chondral lesion. So in summary, cartilage mapping sequences image biochemical properties of articular cartilage. This has shown potential to detect cartilage damage earlier and with greater sensitivity. It's primarily important to be familiar with them when evaluating the orthopedic literature, but gradually you may start to see these in clinical use. Okay, on to assessment of repair cartilage. This will be usually following cartilage surgery. The clinical indications may be persistent or recurrent symptoms. This is also a research tool as an objective evaluation of various treatments and modifications. Following microfracture, a defect will fill with repair fiber cartilage. This shows increased T2 signal compared to hyaline cartilage. The subchondral bone edema should decrease over time following the microfracture. So we'll look at the degree of filling, the morphology of the tissue, the extent of peripheral integration, etc. This is a patient with trochlear chondromalacia. And then post-op, 5 months, we see there's good filling of the microfracture site with fiber cartilage. The signal in the cartilage is a little bit heterogeneous compared to the normal hyaline cartilage. The degree of filling the thickness is almost the same as the adjacent normal cartilage. And on the right, we can see the color map shows some T2 prolongation, which is what we expect. Following ACI, a defect will fill with hyaline-like cartilage. This will initially be hyperintense on T2, and then gradually the signal will approach that of the native cartilage. We can use the assessment parameters in the MOCART scoring system, which stands for MR observations of cartilage repair tissue. We look at the degree of filling, which may be complete, incomplete, or hypertrophic, integration of borders, etc. This patient is status post ACI 1 year ago. This is a normal appearance. We can see good filling with cartilage. The signal in the cartilage is slightly heterogeneous, which is normal at 1 year. The surface is smooth. The borders are well integrated. Standard image on the left, T2 map on the right. We can see the T2 map orange colors are almost the same as the normal articular cartilage, just slightly abnormal at this point. This patient has a large osteochondral lesion with a displaced fragment in the intercondylar notch. Underwent ACI at 1 year. There's knee clicking. So we can see that there's Partial healing of the bone. There's good filling of the lesion with hyaline-like cartilage. The signal's a little bit heterogeneous, which is okay at 1 year. However, the graft is hypertrophic. We can see it's protruding past the normal radius of curvature. Again, on the coronal views, good filling with hyaline-like cartilage, but we have graft hypertrophy. This patient had ACI 6 years ago, and you really can't tell where the lesion is. I mean, it just basically looks normal. This is the site of ACI, and it's basically very hyaline-like cartilage. And on the cartilage mapping, the T2 values are fairly normal. Following Oates procedures, we look at the degree of filling of the defect. By the osteochondral plugs, we look for graft displacement, restoration of radial curvature, etc. This patient had a Oates procedure 9 months ago and has recurrent pain. On the coronal views, this is a normal graft appearance. There's good bony incorporation of the graft. The articular cartilage is smooth and congruent with the adjacent cartilage. When we look at the sagittal views, again, the area of the graft looks normal signal and T2 map. And then there's this area of high-grade chondromalacia just anterior to the graft. This patient had Oates 6 months ago and has post-op pain. You can see the graft here is depressed and angulated. There's surrounding marrow edema. So this is an abnormal appearance. In summary, MRI of articular cartilage will become increasingly important as cartilage repair techniques improve and become more commonplace. The emphasis will be on high-resolution cartilage imaging, and we will see the increasing use of cartilage mapping sequences in research and clinically. Thank you.